Friends, ladies and gentlemen, it's a huge pleasure to be here. Thank you so much for the invitation. It really is a great honor. We have a very long-standing, deep relationship with TMC and the National Cancer Grid of India, so it's a particular pleasure to be here. I have a few minutes really to talk a little bit about an issue which I think is quite pertinent to what we're talking about, which is around yardsticks for evaluating healthcare delivery. And by yardsticks, what I'm really saying here is about measurement here. Let me see if I can get this to go forward. So why is measuring our healthcare systems so important? And the simple answer behind this, of course, is not everything that people claim to be so, in terms of outcomes of patients or improvements, is reality. Take this, for instance, a new technology from the UK. It's a breath spray, which gives you an instant British accent. You sound richer, you sound smarter, and you even look more attractive. Of course it's not right, this doesn't do anything, but the point about measurement is it's there to ensure quality and it's there to ensure better outcomes for our patients. So we can talk about quality measurements, we can talk about outcome measurements, we can talk about indirect measurements through economics, we can talk about access indicators, and it really depends which area you're in, depends on which types of indicators and measurements you're interested in. But broadly speaking, I think measuring outcomes and indicators really puts everything on a public domain and puts it on a level playing field. And this is quite important because at the end of the day, when we're talking about the delivery of healthcare, be it public or private, the issue is about transparency. It's about quality of the care, and it's about improving outcomes, irrespective of which individual areas you go through. But, and there's a big but here, disease and diseases per se are complex adaptive systems, and we often talk about generics, but of course within any particular disease area, the markers of quality, the indicators of quality, the metrics of quality, outcome indicators can be very different. Mental health is not the same as cancer. And so we're dealing with an area which can often has to be done in a very sophisticated manner. And of course healthcare systems are very dynamic. They're non-linear as well. And they're composed often of individual agents who, frankly, behave according to their own social norms and structural norms rather than the needs of the system. They're very self-organizing, and often you don't get a single point of control, and behaviors can be very unpredictable. And that makes it tough in terms of changing outcomes when you're looking at quality. So do yardsticks matter at all? Does measurement actually matter in terms of public policy? And let me just show you a little example from the area of oncology. Here we've got basically case fatality rate here of prostate cancer against healthcare cost per instant case adjusted for price differentials for prostate cancer. These are all the European Union countries, and what this basically shows is when you plot this out, you can see an inverse relationship. The more money you spend, the seemingly worse outcomes you're getting in prostate cancer. This is absolutely true data, and the reason is these countries up here, Greece, Romania, Hungary, Slovakia, have essentially got very fragmented poor care, yet they're spending enormous sums of money. So actually measurement can tell you an awful lot structurally about systems, and it's very good for comparing systems to systems. Patient outcomes, though, are composite endpoints, and one of the tricks and difficulties we often have is trying to work out which yardsticks really matter. What do you have to look at? And this, again, requires a level of sophistication and understanding about a particular disease area and the individual areas that focus in on that to ensure that you actually measure something that will actually make a difference. The one name for quality control is this gentleman here, died in 2000, Avedis Donibendian. The Donibendian system, quality control, I think is really the heart of quality assurance systems. And Avedis, who was an Armenian, spent most of his life working at the American University of Beirut, really pointed to three areas if you're talking about the measurement of quality: structural measures, process, and direct outcome measures. But he made a very important point that he said, look, systems awareness and systems design are important, but they are not enough. They are enabling only. It is the ethical dimension of individuals that is essential to a system's success. The point here is you can cheat systems. You can use metrics to prove things you want to prove. So it comes down at the end of the day to the individual moral and ethical boundaries that we have within medicine in choosing the right metrics and interpreting them in the right way. What about these different metrics of quality and how do we use them? Well, it's interesting because there are a number of them, structures, process, and outcomes, and they all have their pros and they have their cons. Outcomes, for instance, here, in terms of looking at outcome metrics, they have obvious face validity and they have this Hawthorne effect. By that we mean if you study something, if you try and measure something, often it improves. You know what it's like, you have your children there, and if you stare hard enough at them, they tend to improve in terms of the amount of homework they do, just by sheer dint of staring. The same effect occurs in medicine. But of course, it's very tough to measure when the baseline interventions are low for those risks. And unfortunately, we tend to measure what is easy, not necessarily what we need to measure. Take a look at this, for example. This is just surgical volumes and their relationships to basically decreases in operative mortality in types of cancer surgery. So this is a very old paper from Bertmeyer. Upper GI surgery, pancreatectomy, complex bladder reconstructions and lung resections. And these are the percentages due to increased market concentration. In other words, high volume of research, a high volume of surgical procedures. Very easy to measure. But the other thing that actually is really important is this thing he calls other, which turns out to be this complex issue around performance. Preoperative care, intraoperative care, and postoperative care. Very hard to measure. And therefore people often don't want to measure it, but look how important they are. So the point here is, it's not necessarily the low-hanging easy fruit that's important. You often have to go after the hard metrics as well. Basic framework for measurements for yardsticks in the public and private sector are very well worked out. And this is an area, I think, again, time and time again, both in the public and private sector, we fall over because we don't do this properly. It's around efficacy, can it work, does it work, the effectiveness, and is it worth it, the value. And these are now very well worked out research and policy domains, evidence-based medicine, health technology assessment programs, and cost-effectiveness research. But again, it's not a question of whether the public or the private sector do it well compared to the other. The reality is, whatever country you look at, there's often quite poor practice in these individual areas. And designing measurements and yardstick means you need to understand what can go wrong as well, because that's essentially what you're trying to do, is to work out where the system is likely to fall down, where's the weakest point, and plug that weakest point with proactive measures in terms of measurements. And that can be around structural opacity, that can be limited capability, issues around the expertise of your staff and the quality of that. So that requires often a lot of subjective insights into particular areas to build these sorts of yardsticks. So where are we now in delivering healthcare, in terms of evaluating healthcare delivery? Well, it's not enough just to know, you have to use this to change things. It was wonderful to hear Zambian colleague earlier talking about the work they'd done around the Cancer Surgery Commission, because it was not just a question of taking those numbers and working on those numbers and understanding what the deficits were. It was turning those measurements into actionable policy. And that's absolutely critical. Again and again, we often measure and we don't follow through the evidence to policy changes. Effective yardsticks need carrots and they need sticks. And there's often a great argument about the carrots. Is these economic carrots? Are these ego carrots? But we also need punitive measures when people often fail very heavily in delivering outcome measures. And this balance of carrot and stick is really essential. It's very different for very different cultures, and you need very different political structures and professional structures. But the reality is you do need some sort of leviathan. The idea that the market by itself or the public sector by itself will have this emergent, wonderful quality and fantastic outcomes is simply not true. It's never happened in any healthcare system. We know previously that the MDGs were pretty good, but they were insufficient. They failed to cover many different areas in terms of our global outcomes from government. But I think the problem we're going to have to deal with going forward, of course, is moving into the Sustainable Development Goals, is just the sheer number of indicators now in the health area that national governments are supposed to be reporting on. And actually seeing from the wood from the trees, in my view, is going to be extremely difficult. But this is going to be one of the big challenges for national healthcare systems, is plugging into the indicators that really make a difference, and also having other indicators that may be not a part of this group, which are equally important. The future yardsticks, challenges and benefits. This is I've seen, I think this 3 or 4 times. This is a really popular model, and for good reason now, of course. This is the model for UHC. It's around the grand convergence of Dean Jameson and all of that. I like it a lot, but it has a lot of limitations. It can be seen as quite unidimensional in many areas. And again, I think the question really is, what sort of yardstick measures do we need for quality and for healthcare outcomes beyond the coverage and the economic indicators that are embedded in these sorts of models? And of course, something I think we'll come on to again tomorrow is, where are the yardsticks for fairness and justice in society? It's not simply about healthcare in terms of the delivery of care. We're talking about social justice here, patients who present early enough, patients who are able to have affordable treatment, who don't fall into catastrophic expenditure. So building in measures for fairness and justice from the social determinants point of view, in my view, is equally important and need to be balanced against the focus purely on disease systems. And it's sort of, this is the last picture really to remind me to say to you that when it comes to metrics and to describing things, we can often do things superficially very well. We can look at something like this and describe all the rooms and the edifices. The problem is, what you can't do is see behind here what's actually going on. And half the trick in building yardsticks for healthcare systems and for evaluating them is to get inside those rooms and see inside that. And that goes beyond the numbers. That is about qualitative research. That's actually about on-the-ground intelligence rather than the pure numbers. The numbers will only just simply describe the edifice there. So you need both things to actually achieve this. Thank you very much indeed.